to the second of our two webinars on the Investment and Impact Fund. Today we're talking about the high quality care and sustainable NHS domains. The previous one was on prevention and tackling health inequalities, and there's another webinar we have recorded on the website. Please obviously switch off your cameras and microphones. The session is being recorded. This is an interactive session, so there's going to be opportunities to ask questions later. Please add them in the chat, but if you're happy to, we'll ask you to speak directly through to them towards the end. Quite a lot to get through today. With me here, my name is Carvalho. I'm one of the clinical leads at CEG. I'm also with Mike.
Hi, my name is Mike. I'm one of the GP in City and Hackney, and also one of the clinical leads here at CEG.
And Joe.
Hi, I'm Jo here. I'm one of the senior facilitators at the CEG.
And Max.
Max, I'm a GP in City and Hackney and another.
I'm going to hand over through to Mike to take us through. You'll hear different voices as we go along. The main thing is to have a look at the screen, have a think about how you are doing your performance in the indicator, add in comments into the chat and any questions as well. So particularly this is an interactive session, so we want to hear how you are achieving the indicator, what you are doing within your practice, PCN, your boroughs, and how you think things can be improved and how you can work together to improve your performance. Thanks, Mike.
Sure, thanks, Chris. So today, yeah, as Chris mentioned, we're going to be talking about the providing high quality care and sustainable NHS domains of IIF. We already covered prevention and tackling health inequalities in the previous webinar, and that webinar has been recorded, so it's available to watch. So looking at the first set of indicators, enhanced health in care homes, this is looking specifically at adults, so 18 and over. The first indicator really is looking just at how many of your care home beds are properly on CQRS. So it's just making sure that all of your beds have, you're recording that on CQRS, you've submitted that so that it's reflecting properly. As long as you've done that, you should meet the indicator, no problem. The second one is looking at care home residents who've had a personalised care and support plan, so PCSP, agreed or reviewed. Now, we have support searches to help with this. What's really important here is to make sure that you've coded on your clinical system that the patients are living in a nursing or residential care home, so you can probably find those and check that they've had their PCSP agreed and reviewed. You can essentially exemption report them, so that's called PCAs in IIF, by either coding that they have declined to have a care plan, a support plan reviewed, or also that they have declined registration with the GP that's aligned to their care home. Basically, that if they are eligible for additional support provided by the network contract is if they register with the GP that's aligned to that care home. So if you're not that surgery, then you can opt them out. The next set of indicators about care homes is looking at the mean number of patient contacts as part of weekly care home rounds per care home resident. So it's looking at an average and looking at that there's at least 6 or 8 patient contacts per care home resident. Basically, the long and short of what you need to do here is make sure that the on your appointment books that your care home appointments are mapped properly. We have sent some instructions out for how to correctly map those, and we can send that out again with the slides today. If on looking at those instructions you're still unclear, there's any uncertainty, do just get in contact with your local facilitator and we can help support with that. Edenbridge Apex is a really good software package to allow you to see what your performance on this is. There was another indicator looking at standardised number of emergency admissions, but that has been deferred to next year. Moving on now, there's the next indicator we're going to look at is one for standardised number of emergency admissions for specific ambulatory care sensitive conditions per registered patient. Now, honestly, one's a really tricky indicator for us and for general practice, because we don't really have access to any of the data sources here. They're pulling this data from the Hospital Episode Statistics, or HES, which is something that we therefore can't see. So you can't really see how you're doing with it. And the actual list of ambulatory care sensitive conditions is very hard to nail down and clarify, because it refers specifically to those HES codes. So, there's just 1 second. Lovely. All right. So, really, what the fundamentals of this, what they're trying to achieve, is making sure that long-term conditions are effectively managed in general practice, and also ensuring that acute presentations are kind of rapidly responded to. And if you look actually at the thresholds, if you just have the same amount as you did last year, you've already met the lower threshold. So it's just ensuring that that's not increasing. It's tricky for us to really advise on this one, because there's not a way for any of us to see where that data is coming from. If we move on to the next indicator, this is about so the cancer indicator is looking at fit tests for patients referred via the lower GI 2-week wait pathway. There has been a change with the new update about the time period. It gives us a bit more flexibility now. So long and short of it is that you need to have referred a patient within 21 days of a positive fit test result. If you're sending them for a lower GI 2-week wait and they don't already have a fit test result done, it needs to be done within 14 days after that referral. The exceptions are if you're referring for anal ulceration or anal or rectal masses, there needs to be an appropriate code to clarify that. The other exception is if they decline a fit and then don't subsequently do one, that will PCA them as well.
So just to emphasize, one of the key things that to pick up on this is the fact that the fit test, when it comes back from the hospital, the code we need to link back into the records. So there's some instructions that we've had on this. That's one key information which we'll also share back afterwards. The other aspects is just another plug for the cancer safety netting toolkits package that we have, CEG, which again we did a webinar on recently. Lots of great support within that to help you manage this, and also how you do your cancer safety netting, and also there's a reflective template tool within that as well. So a big plug for that as well, which hopefully should help partly with this, but also to help improve cancer care within North East London.
Thanks, Chris. So we'll send out the instructions for how to map the fit test results with that fit test code. You only need to do that once, so if you've done that already, that should already be sorted out. So the next set of indicators are about access. So the first one is looking at pre-referral specialist advice and guidance requests. Now there are 12 specialties that they're looking at. So cardiology, dermatology, gastroenterology, gynecology, neurology, urology, pediatrics, endocrine, hematology, rheumatology, respiratory, and ENT. So ultimately what they're looking at is the number of referrals first outpatient appointments to those specialities, and against the number of advice and guidance requests across those specialities from your PCN. One way of addressing this would be looking at actually doing your referrals via advice and guidance, and there is generally a push to using advice and guidance as a pathway into referral in order to try and reduce unnecessary referrals and waiting times. The way to do that would be you would do your advice and guidance, kind of asking them to see the patient as well, and ticking the option that allows them to convert that advice and guidance directly into a referral. That would be one way of looking at it, of addressing this, and you would certainly achieve the indicator threshold by doing that. The next indicator is about referrals to CPCS, the Community Pharmacy Consultation Service. And we'll go through the list of CPCS kind of amenable symptoms, but what ultimately is going to be looking for is that there needs to be 34 referrals per 1,000 patients per year, and it's looking for those specific codes that we've got on the side there. So the referral to the Community Consultation Service.
So just to say on that, for the referral to CPCS, there is a way to do that through the through EMIS. System 1 practices will need to educate me on how to do that, but there is a way to access that through the local services button. Now, overall, this is a scheme which is there to help primary care to deal with some conditions which can be best managed elsewhere. It's obviously up to the practice about how they engage with that, but these are the list of conditions which, as you can see, are generally low or minor ailments that many patients will be consulting with, that perhaps our pharmacy colleagues may be better placed or at least able to support patients with. So as we move forward and we think about how we engage with our wider community and primary care colleagues, this is a way for patients to start to acknowledge how to engage with those out there in the community and try and access healthcare in a different way. There is a quite a large number of patients that will need to be referred to achieve this indicators. For 10,000 size practice, that's around 340 through the years. So there's a large number of people that would need to be formally referred and coded through this. But I think hopefully you can see in through that list, there's probably a number of ways in which you could direct your patients, ideally at reception, to access our pharmacy colleagues to provide this service. And having talked to a number of the pharmacists, are very open and willing and happy to take these patients on and direct them away from care. So have a look at that, see how you are accessing and how you're working with your practice colleagues within your practice, your receptionists, direct your patients through to them. And obviously this is a practice and a PCN decision how you do that, but would recommend engaging with your local pharmacists on how you can take that forward.
Thanks, Chris. So there are a number of access indicators that have actually been deferred through to next year. So one about online consultations, and another about time from booking an appointment to the actual appointment itself. That's been deferred to next year. One of the other access indicators has actually been retired completely, which was about developing a plan to improve access and identifying inequalities. The next set of indicators are about structured medication reviews and meds optimization. So we'll kind of go through each of these in turn, but they link in with some other indicators that are coming up later in the talk. So the first one is looking at potentially adult patients who've had an SMR who are classed as being at risk of harm due to medication errors. Now there's a list of kind of combinations of medications and age groups, which we'll come on to in the next slide. So put pause on that one for now. There are some kind of sub-indicators as well about patients with severe frailty who've had a structured medication review, and they define that as having a code of severe frailty coded or an EFI score of more than 0.36. There's an indicator for SMR in patients on potentially addictive medications. Again, there's a list of those. We'll come on to that in a moment. And another one about permanent care home residents that are 18 and over. So if we're looking at the risk of harm group, it's a combination really based on kind of age and medications. So I won't necessarily rattle through all of those, but as one to refer to, and we have a set of searches that will kind of help you assist you with this. And this is ideally something that PCN pharmacists can have a look at and work on for practices. But if anyone has anything that's been working well for them, they want to put in the chat, that would be great. We've also set the search, just to be aware, rather than patients that are aged 18 currently, it's patients that will have turned 18 by the end of the reporting date, and that way you're not stuck with a really short time to sort out patients who've kind of turned 18 very, very close to the end of year. So if anyone gets a bit confused as to why 17-year-olds are coming up in that search, that will be why. Coming on to back to the SMR indicator for potentially addictive medicines. So again, it's about specific medicines, and our searches will help you identify and find those patients. So it should be easy to find out who they are and then work through those patients. The slides will also be available kind of at the end, so I'll move on from that. Before I mentioned about that there was going to be some linked indicators to the previous one about patients on high risk medications, and these are those really. So but rather than looking that they've had a medication review, it's actually trying to improve the safety for those patients. So it's trying to find this indicator is looking for adult patients who are on both an NSAID and an anticoagulant, and either stopping their NSAID or making sure they're on some kind of gastroprotection. So by doing the earlier indicator, you will inevitably address this indicator as well. And the same goes for the next one, which is looking at patients over 65 who are on an NSAID without gastroprotection. And that's the difference between those two. Similarly, further linked indicators about being on anticoagulants and antiplatelets, and another one about being on multiple antiplatelets as well, and making sure that they're either just on one or have some gastroprotection as well. The last SMR indicator here is looking at patients who are on DOACs and how we manage their kind of renal function results. What this one is looking at is it's requiring for every time a renal function comes back that a creatinine clearance is recorded along with a decision as to whether their DOAC dose has been changed or unchanged, and there are 2 codes to easily clarify this. Our searches are, our updated searches include DOAC unchanged codes within them, so the indicators should be nice and accurate when you're looking on the dashboard about your performance. That was the description medication review indicators. But sticking on a medicines theme, looking at respiratory medications. So these 2 indicators are about patients who are on the cough asthma register. The first indicator is looking at inhaled corticosteroid usage, whether that be as a sole ICS or as an ICS-LABA combination in the last 12 months. And what it's trying to ensure is that patients who need inhaled corticosteroids are getting them regularly. So there's kind of two parts to this. First of all is making sure that they're actually getting a regular ICS, but there's also a part of it that's looking at patients who don't need inhaled corticosteroids and ensuring that they are coded correctly and being managed correctly. So a way of PCAing patients out of this indicator is if they are coded as having mild asthma. So ways of looking at this will be through asthma reviews and also looking at their asthma control test score and looking at whether these patients can be stepped down off ICSs if they're not needing them so regularly. This is looking at trying that this indicator is looking at trying to improve that, so the thresholds are going upwards. The next indicator is actually trying to bring that target downwards because it's looking at short-acting beta agonist inhaler prescriptions in the last 12 months. Now, interestingly, this indicator this year isn't looking at the number of salbutamol inhalers, but it's looking at the number of prescriptions. Next year, it will be looking at the number of inhalers, though. So it's just something to consider and making it easier to meet this. So if you've got patients who are so children, for example, who are needing inhalers in multiple settings, so one at mum's, one at dad's, one at school, for example, it might be worth considering whether those are put on one prescription because that will just count as 1 rather than 3 for this year. The other thing to say is if prescriptions are, say, accidentally printed non-EPS rather than being sent EPS, is making sure you cancel that non-EPS prescription before resending it. Otherwise it will come up as 2 prescriptions even though you've only issued it once. And if you've sent something to a pharmacy via EPS and then the patient saying, actually, I don't want it at this pharmacy, I want it at another pharmacy, rather than re-prescribing it, it's getting the patient to tell the pharmacy to release that prescription back onto EPS, so another pharmacy, their pharmacy of choice, can pick that up, and that will still only count as 1 prescription.
But this sounds all very confusing and quite complex in how it's going to be done, and there is some difficult, I think, understanding of the rationale behind this, and I think we could get confused that we are saying that all patients for RESP-O2 should never have SABA prescribed more than 6 times. But just bear in mind that there is a threshold there, and there is a space in the gap for those exceptional circumstances where there may be patients who I might say have needing have inhalers at different sets of parents, at schools, and also for a lot of my patients, they use a lot of inhaler because they are actively exercising and they take before every exercise they do. So within that 15%, we would hope that there would be some allowance for those cohorts of patients, which is may or may not be enough, but there is obviously a range there. It is okay for us at the moment because, as Mike said, with the way that data is extracted, it is per prescription currently. So you could have on a prescription 4 inhalers, but that won't pick this up at the moment. Next year it will. At the moment, on that prescription, you could have multiple inhalers being issued as part of that single issue. Coming back to Respo 1, I think one thing to really emphasize, as Mike said, is to look to identify those patients who are mild, who do not need to have an inhaled corticosteroid or a LABA. If you code them correctly, as in of having mild asthma, then you won't need to then put them into this group and prescribe the inhaled corticosteroid. It would be inappropriate for those patients to have that. If they don't need it, they shouldn't be prescribed it. So it's important that we identify them in our system with the correct codes, and that we've done the right thing to identify that they do not need to have medication that this indicator would suggest they would need to be on to achieve it. Quite high threshold on that, but this is clearly something that we need to get right, otherwise we could be inappropriately prescribing. Thanks, Mike.
Thanks, Chris. So that brings us on to the kind of final set of indicators that we're going to be talking about today. So about sustainable NHS and environmental sustainability. So rather than looking at asthma, this is looking at all prescriptions for inhalers for all groups. And it's looking, the first in ESO1 is looking at meter dose inhaler prescriptions as a percentage of all non-salbutamol inhalers issued to patients 12 or over. So really it's looking at trying to switch patients onto dry powders. Now, the code that will exclude patients from that is dry powder inhaler, not into, just to be aware of. But a way of looking at this would be trying to, when you're doing medication reviews, would be looking at trying to encourage patients to switch over to a dry powder inhaler, and there are significant benefits to doing that environmentally, but also some patients find it better. A lot of them have dose counters on, and certainly it can be a little bit easier if patients have a very good inspiratory effort. The next indicator, ESO2, is looking at carbon emissions per salbutamol inhaler prescribed on after the 1st of October of this year. Now, this one is a slightly tricky one to actually nail down the exact carbon emissions that you're doing, but as a general way of achieving this really is switch. If you switch people over from the higher carbon footprint salbutamol inhalers to one of the lower ones, so specifically the Easyhaler salbutamol, which is a dry powder inhaler, and the Ventolin Acula, another dry powder inhaler, you should really achieve this indicator. Anything that you want to?
So just to highlight one of the difficulties that we will have in achieving this, and this goes to all of the way that the data is collected, is a difference between how the national team will look at this data and the data that we have available to us. The way that we work within CEGs is that we extract the data through EMIS and System 1 of what we are doing for our ends as GPs within practices. So we have that set of data. Overall, the national team are looking at different sources of data. They're not just looking at the primary care data, they're also looking at hospital data from outpatients, from A&E. And for this indicator, the main source of the way they are going to look and see that this is being achieved is through pharmacist data, and actually in the way the numbers of prescriptions which are picked up. Now, as you can imagine, there will often be times where you as a clinician or you as in the practice will issue a prescription for an inhaler, and then the patient may not pick that up. And so it's difficult for us to know from our side where we are in terms of that performance. That's then left us with a difficult position as to how we demonstrate what your achievement is at the moment. However, if we take a step back and think about the principle behind this, what they're asking us effectively to do is to reduce the number of inhalers prescribed which have a high carbon emission. And then for us within primary care, perhaps the quick win there is to do conversion of those ones in red, of those high carbon emission inhalers, onto those which we know from the data that we've been supplied with by the national team, onto those green inhalers, those ones which are the low carbon emissions. So as part of a medication review and a discussion with the patient to explain the benefits of this and the rationale behind it, that would be a process to go through to then automatically convert those ones over. Hope that is clear, and I hope you understand the difficulties with that indicator. And I think we all know, having done this type of conversion over the years, that it can be quite difficult to for some patients to accept that conversion. However, I think again this is another one which has some leeway with those thresholds. It's not to say that won't come down, but currently there is some leeway for us to have patients on some of the higher ones if that is their preference. The other thing to note is that we have done a lot of work over the years to get people off branded inhalers and onto the generics. So there is ongoing work with our pharmacy colleagues to make sure that the prescriptions of those inhalers are the correct ones on that side as well, to make sure that we are the pharmacists are issuing those ones which are still the low carbon inhalers, and it's quite clear on there that we are specifying those inhalers to be issued wherever possible. So there have been discussions with the medicine management team to make sure that is agreed and appropriate. But this is obviously a national push and a national ask which we are being incentivized to for.
And that brings us on, so that's the end of all the indicators. So time for questions now. So we'll have a little look through the chat and find some of these. The other thing to say is just looking at actually how we can support you. So obviously questions today that we'll go through, but also if you've got questions going forward, our facilitation team can help you. We've got searches to help identify patients that have outstanding things that need doing to meet the IIF criteria, and templates to help you meet those criteria for those patients. Provide practice visits, either virtually or face-to-face, and there is a dashboard that's updated monthly to allow you to see not only how your practice is doing, but PCN and the boroughs as well. So these are contact details for the various facilitators for the different boroughs. So I'll leave that slide up so that everyone can see and jot those down.
So just while people are putting their questions in the chat, there's already been a few, some of which we've answered. One of the key things of our next steps is how we work as practices, how we work within our PCNs and within our boroughs to achieve these indicators. For two reasons. One, I think, which is the one that's probably very appropriate for us as we think of ourselves as businesses, which is the financial aspect of achieving the income that is associated. But the other side is the clinical aspect of making sure that we are doing things that are clinically right and justified, that are mentioned in these indicators, but also with our own interpretation of them. So it's really important that we as a system, as a place, as practices, look at how we are working together as our groups to learn from each other and to achieve these indicators. This provides a huge amount of investment for us, and so it's important that we think about how we are going to tackle these and to what degree we want to. That's not obviously for us to decide at CEG, but that's something for you within your practices and within your PCNs to determine. But as I say, there's a huge amount of investment that's coming in this way, but a huge amount of workload as well. If we look back, and the way that we've often described the IIF is that this is QOF for PCNs. And one of the successes that we have had as CEG is the way in which we have supported practices to achieve their indicators through the facilitation team, that hand-holding, that ongoing support, the use of searches, the use of the templates, and the dashboard. In the first session, you will have seen that we demonstrated the dashboard, and we've included in this the link as well to that, so you can have a look. In discussing at networks, one of those successes in the way that we have worked is the demonstration of performance in the data in a non-judgmental fashion. So within our networks, within our discussions, having an ability to see our current performance of where we are as a practice is a great way to know how we can improve, or in fact that we need to improve, and then learn from others on how we can improve and work collaboratively to do so. That visual representation of our data and our performance helps us to understand where we are and what we can do going forward. As I say, this is something that we have done for a number of years and have lots of experience with, which you will have as well. The offer is still there for us to come to your PCNs, to share with the data, and to help work through what that means, how to use the searches, how to use the support searches which are there as well, how to use the templates, what that performance means with those charts, and what you can do to move forward. I'll stop there for a minute, though. We've got some questions in the chat. Because this is being recorded, you won't have seen, if you're watching this afterwards, some of the questions in the chat. So we'll just go through any of those that have been answered. One of the key things that people ask with this is that whether this will be shared afterwards. So we'll have the recording and the slides available afterwards. Within these slides, there are links. So within this slide, as you can see here, there are the links for the email, so you'll be able to click on those. Similarly, there are links and more documents which we have links to in the separate slides, which you'll be able to have access to. In addition to the slides, there's some information that we've gone through that we'll provide afterwards, particularly around, for example, the fit coding and on the information on how to do that. Some of that we should have shared already, and if you've got that, great, but we'll share it again afterwards. But yeah, that was one of the first main questions we've asked. There was a question around the code for patients who have declined the referral to the community pharmacy consultation scheme.
So it'll only count successful referrals. So if they've declined, that unfortunately won't count towards meeting that indicator.
So yes, so the ask there is to achieve 34 patients per 1,000, and so they are counting the 34. Now, unfortunately, it means that you won't be able to count towards that if they have declined it. But I think it is important to code that you have offered it and that they refused it. So we've put in there the refusal code, and we'll send that through as well. So I think it would be important to identify that is happening, and it's something that we could have a look at afterwards. There's a comment in there around RESP-02. This is the one around the number of SABs, subbutyl inhalers, prescribed, and it needing to be below 6. Comment is that this is almost impossible to manage, especially for children. In reality, so many patients lose inhalers, need extras for work, etc., and we may have to prescribe otherwise. They could be left without. So it's a very difficult call. I very much agree with that point. I think it is very difficult, and there will always be those issues where patients will need more than they will necessarily have prescribed on the usual amount to have it in as a spares. Whether that's, as we've said, with mum, with dad, even with gran and grandpa, but also with school work or otherwise, just in case. That safety net, I think, is really important because we have so many patients who are attending hospital and suffering because of their asthma attacks and not having access to their inhalers. But within the indicator, there is scope for those patients to be accounted for within that, I think it's the 15% threshold. So what they're asking is that for up to 85% of patients have fewer than 6 prescriptions in the year. Those people who have the exceptional circumstances, those will be in the rest of the 15%. What we don't know is whether that is right for our population in North East London, and whether it may be right in Tower Hamlets and or not right in Tower Hamlets and right in BHR is difficult to see. However, there is a threshold there, and I think it's important that we understand what is clinically right to do and to think about what is then the indicator as well. These are a new set of indicators, and I think there will be a lot of feedback, and there has been a lot of feedback, which I will share with you in a few minutes, on some of these indicators which have meant that they have changed. So we will share any feedback as well that we can up to the teams, given channels that we have access to. But yes, very good comment, thank you. Next one. So in some areas you will have script switch, so I think so you have Optimize RX, and currently at least one of those is recommending that salbutamol prescriptions are changing to Salamol rather than easy inhaler salbutamol, which I think the commenter said is likely due to cost. And there was another comment saying that it is just over double the price. That is a difficulty, and I think it is something that is a difficult balance to strike. I think the difficulty for us then is that you're getting mixed messages on the front line. I think that's a really important thing that we will take forward with medicines management. But there's another comment there as well, which I'll just read out. It says, maybe because Easyhaler is often not appropriate in asthma. DPI is good for pre-exercise with mild symptoms, but respiratory effort means that there is not safe. That is not safe for use in acute asthma or when. Clearly, there's more discussion to be had on this, and I think what we would need to make sure is that we have good guidance from our respiratory colleagues. Like I said, there is a threshold within that which allows us to have some exceptions within there. But I think there's a comment there that perhaps we should go through to, we should direct through to our respiratory clinical leads for further comment on. I'll take that on, but thank you. That's a really good point and really good discussion. As we've said, this is not a transactional webinar. This is not something that we're coming along to tell you how to do, but this is something collaborative to help us to understand how we can, as an organisation, as a now ICB, improve our performance and achievement on. But I think if there are difficulties in achievement or performance, then you should feed that back, but make sure that you've got the right information to take things forward. There's another comment here which is, will referral for BP check count for CPCS referral?
Alas, no. Unfortunately, it's specifically looking for that code that we listed about referral to CPCS. That's the only code that will include you in that indicator.
Now, one of the things that we have always recommended is to work with our wider primary care workforce, and that we aren't always just thinking about GPs, but also thinking about who else is working within the practice. And many of us would have seen the benefit of working with our pharmacist colleagues who are incredibly skilled to be able to support, particularly with these indicators. But there is a lot of work involved, particularly around the medicines here. And within those SMRs, the structured medication reviews, common is that the SMR activity required is higher than the resources of pharmacists. Obviously, within us, within CG, it's not something that we have a huge amount of influence on, but it's something that we can flag up. I think it's a discussion at PCN level is how you take that forward and what work is prioritised by the pharmacist, what work is done within the other GP workforce. But certainly, yes, there is a lot of work there to be done. I do hope that will decrease as we go throughout the years with the IIF indicators, although we can't guarantee that. But there is something there about the prioritisation of that workload. I would strongly recommend that you have a look at that in a coordinated fashion through the collaborative piece that we're asking. Okay. There's a comment here about a patient who keeps coming up in SMRO2A. He's on rivaroxaban, he's 62, and he's used NSAIDs once in February 2022. I spoke to the GP and he's no longer on both drugs together. Does not need to be on PPI, but the patient's still coming up on this target. So a good comment from Ranjan on this. And this is a great example of our resources here, in that she's upset to let your facilitator know so they can look into why this patient is coming up. A great example of how our facilitators can help support practices on achieving these indicators.
Just to come in quickly on that one, so with SMR2A, so it's looking at people that have been on those that are either no longer prescribed an NSAID or prescribed gastroprotection in addition to an NSAID and or an anticoagulant. So depending on which way you're looking at it, if you're looking at it from the achieving indicator point of view, that might be why, if he's no longer on that. But again, if you just get in touch with the facilitator, and we can clarify that one.
Thanks. There's another comment about the data that we have access to, and as I said, we have access within CG to the data that we can access through EMIS and System 1. But there are other sources of data that are being used for this indicator, some of which we have better access to than others. And the one was around ACC02, which is data through health hospital data. And the comment was to ask someone in the place-based partnership who was looking into this for an update on being able to access that data. Absolutely, we are looking at that, and we will hopefully try and get an answer back for you. It is an important thing to have access to understand the performance. I looking at the data that we would need to help with this achievement on the IIF. It is really important that we do have access to all the data that they're using. It has been a struggle, I have to say, to get the data that we need through the GP records. But one of the things that we want to do is be able to look at our data through hospital data, whether that's HES, SUS, EROC, all those are acronyms, but hospital data, primary care data, and pharmacist data, and other sources that they are using, so that we know how we can improve. Because unless we have access to the data, we don't know where we currently stand. We don't know what we need to do to improve to achieve that performance and those indicators. So absolutely, yep. Hopefully, we are going to be getting access or finding out ways to be able to give you the data that you need to achieve on this on these indicators. So I think there's another comment about I think it's SMR02, another patient coming up. Search. There are some difficulties, obviously, in the way that the searches are written by the national team, which unfortunately it is down to us to be able to work within. But I think this is another one for us to have the facilitator look through and give you some guidance on the individual patients as the best way forward. Lots of questions there. I think there'll probably be some more coming up, but I mentioned earlier about some of the feedback that we have been giving through to the national team about these indicators. And when they first came out, one of the indicators which we talked about last time was called CBD04, which is to identify patients who have a high cholesterol and refer them for assessment for familial hypercholesterolemia. all you had to do is run a search, find out who had high cholesterol and refer them, which as an indicator perhaps wasn't written in the best way, and unfortunately meant that large numbers of patients were referred to secondary care and not in a way that we would normally do it. We as clinicians will assess patients and take it to the best of our skill set, experience, our knowledge, and refer as appropriate. This indicator effectively took out that process, and it wasn't appropriate for us to refer large numbers of patients who hadn't been worked up. And so for our secondary care colleagues, there was an increase in workload. But actually for us, it meant a lack of appreciation of our skill set for me. And that it meant that we were referring people in when actually there's more we could do in primary care. And for patients, it wasn't ideal either, because they were being told that they're being referred for a condition which is potentially life-threatening, when actually we would know there's more we can do to assess actually whether they were actually truly high risk and needed to be referred, or whether there was another explanation through a secondary cause, or maybe actually if you put all the information together, they were low risk. In the letter that came out in September from the national team, they reported in that they were looking at that indicator again, and that they were going to reword it so that actually the guidance stood that you would do an assessment in primary care and refer as necessary. This week I've had confirmation that the business rules are being changed so that instead of you being paid for referring, if you find a patient who has a high cholesterol and you have looked for secondary causes and you have checked their family history and you've applied Simon Broom or the Dutch Lipid Clinic network criteria and they are low risk, what you have done there is you've done a clinical assessment within primary care. They would accept the code for assessed for familial hypercholesterolemia, and that will mean you have achieved the payment. Just to repeat that, assessing in primary care for risk of familial hypercholesterolemia will now be accepted for CBD04. You do not need to refer in for that indicator. There is a pathway that we have, which has gone out to the clinical leads within different areas, which is on the NEL website. Takes you through the steps that you need to check for secondary causes, to assess the family history and to code appropriately, and then which patients you will need to refer or how to take the next steps with them. Direct you to that afterwards. But some good news that will hopefully reduce the burden on both primary care and secondary care. Because one of the things that was happening with those patients that were sent up was they were being bounced back. Unfortunately, that meant that the indicator, although it looked like it would reduce the workload in primary care by taking them directed to secondary care, actually it duplicated both sets of workloads because those patients were coming back. Okay. Stop there on that indicator, but coming back to these, really just to emphasize the support that we're offering through those local support teams, the facilitators, the sharing of our data, the visualization of the data and the charts to show where you are in comparison to your peers, and then the facilitation of the discussion on how to improve. That offer is there to all of the PCNs across North East London. Another thing to comment on that we emphasized a lot last time was that you will notice that some of the codes within our searches and with our templates are quite specific. And that's because we spent the time interpreting the rules from the national team to make sure that they align with the codes that are used for payment on local contracts. So where there are contracts which are aligned with the IIF indicators, if you use our templates to get the right codes in, you will achieve on both. So it's really important to use the local searches, the local templates, the ones that we've put together in support of our commissioning colleagues, our contract colleagues, that will help you achieve both sets of contracts. Just looking through to see if there are any more questions. I think that's coming to an end, and we've just got 5 minutes more. Are there any other questions? If anyone wants to put their hand up and comments, if they want to feedback on the dashboard, the searches, the tools, or anything we've covered either today or last time, you're welcome to join in there. If you do have any other questions that come afterwards, please get in touch using those emails that are up on the screen at the moment. Any further? CBD06, any guidance, please? That's a CBD06. I think that is one of the edoxaban indicators. So this is for those patients who are currently prescribed edoxaban as a percentage of those patients who are on the QOF AF register. So just the bit of background to that. So for AF, one of the big risks there is having a stroke, and anticoagulation will reduce the risk and the severity of that stroke. That is applicable for those people who have a transvascular above 2, slightly nuanced in the IIF, but the summary, that's the transvascular above 2. They should be on anticoagulation where appropriate if they are. Traditionally, or previously, we had these patients on warfarin. Warfarin obviously comes with a lot of monitoring, for better or for worse. However, some patients will find it better to be on a once-a-day tablet, or once-a-day tablet for DOAC, which they take without needing to have any more monitoring than once a year. Obviously, there's a cost to the health system of having that monitoring of warfarin. There is some benefit then to only having to do a once-a-year annual review. The other benefit, though, that this indicator is talking about is edoxaban, and wanting the greater proportion of your patients on not only on anticoagulation but DOAC specifically to be on edoxaban. And the reason for that is the National had secured a cheaper price for edoxaban than the other DOACs. So they're now incentivizing you for to increase the proportion of your patients to be on edoxaban. The difficulty here is that the majority of our patients are actually not on edoxaban already. They're more likely to be on apixaban compared to the others. To achieve this indicator, what we have recommended is a couple of things first. The first thing is to look for people who have AF, who have a transvasc above 2, saying that they should be on an anticoagulant, but they're not. The first thing to do is start those patients on edoxaban. The second thing to do is to look for patients who are on warfarin, but do not meet one of the codes that means it's clinically recommended for them to be on warfarin rather than DOAC, and think about switching them, starting them on edoxaban as well. And I think of those patients who are housebound, who may struggle to get to appointments for warfarin and INR checks, onto DOAC and onto edoxaban. Did a lot of work on that at the beginning of the pandemic, so there shouldn't be that many people left. May well be. That should get you most of your patients and do most of your achievement. There will be some that are left afterwards, and we've had a lot of discussion with the medicine management team about mass switching and the workload that is involved. There isn't a restriction on doing that, but I think the advice is that it's not necessarily our first choice to do mass switching. However, it may be necessary to switch people over for purely to achieve the indicator. But that is a decision for you within your practice, within your PCN, within your borough to determine upon. The leftover ones that mean you will need to achieve that indicator. We have, and definitely in City and Hackney, gone out to the joint prescriber group and confirmed that in secondary care, at least in the Homerton, that they are moving for AF anticoagulation, that edoxaban will be first line. The other thing to say is that many of us in primary care are not used to initiating DOACs as a whole. So there is a lot of work going on at the moment to support us with guidance. There is already a lot of guidance out there on what you need to do to initiate, and that will hopefully support primary care. And we're having conversations still with colleagues about how we can support primary care, either through the hubs that are already there, through education and through guidance to help you initiate patients themselves. Hope that clarifies things. And thank you for the comment on the clarifying the familiarity a target. Give me a minute to see if there's any other comments, but we're at 2 o'clock now. I know that we said we're going for an hour and a half, but I think we find it difficult to go on for longer than an hour, especially with everyone being so busy in primary care at the moment. So we'll wrap up there. But if you do have any more questions, if you do drop us a line, either through to the team at CG or through the emails on the screen, will hopefully help answer those questions. Thank you for your contributions today. Thank you for listening and attending. Thank you for, yes, your questions, your comments, your suggestions along the way through the year. We'll hope to see you soon within your networks to do that piece around the sharing of the data and performance and the facilitation piece. We anticipate we'll see you again next year for the new IIF indicators and to go through those again as well. These slides will be shared afterwards along with the additional information, and the recording will be up on the website as well. Thank you all for today, and we'll hope to hear from you soon.